May I ask now Oscar to deliver his lecture on surgical indications of degenerative deformity of spine. Oscar.
Hello, dear friends. It's a pleasure to be here once again. Thank you, Duty and Professor Ramani, for the invitation. And my lecture is on surgical indications for degenerative deformity of spine. I have no disclosures relevant for this presentation. This is quite a big problem because of the advance in medical care translating into longer lifespans. The prevalence is increasing at an alarming rate, and according to different cohorts, almost 68% of population can be showing this problem. Usually it begins at the age of 50, and prevalence and curves increase with age. Older people, they can have around 60% patients that were previously normal curvature of the spine. There is high expectation of the patients for the deformity correction, and you have to be aware also the high overall cost of this disease. ADS is a specific type of adult scoliosis referring to a structural curve that develops after skeletal maturity in a previously normal spine, which we consider a Cobb angle higher than 10 degrees measured in the coronal plane. But if you look at from lateral, from a different perspective, you will discover that most of those patients, they have not only scoliosis, like here, 42 degrees, but also, as you can see here, lumbar hyperlordosis. And it's very important to differentiate adult idiopathic scoliosis from adult degenerative scoliosis. Of course, in degenerative patients are older. Stenosis is much more common in lower lumbar spine. Cobb angles tend to be smaller. Actually, compensatory thoracic curve is rare. It's more frequent, a rigid lower lumbar curve. Rotatory deformity, it's seen at the apex of the curve, and lateral subluxation of vertebral body is very common. And what you should take into account is that sagittal imbalance is very, very common, opposite to adult idiopathic scoliosis. Stenosis is more frequent as foraminal than central, and more common on the concave side of the curve. Coronal imbalance makes interpretation of sagittal MRIs very difficult. I always like this kind of MRI coronal views where you can see the difference in the compression in the concave side. So you have a conceptual quadrilateral understanding of the problem. Because of asymmetrical pathology of disc and facet joint degeneration, this leads to the coronal balance in axial loading, usually multiple segment levels. But you have also lumbar stenosis, sagittal imbalance, and multi-directional instability that you assess on dynamic 6-ways. This is an illustration of the radiographic measurements that you should take on standing spine X-rays, as someone nicely showed. And this will frame your understanding of the disease you are facing. There's showed a very good correlation between radiographic parameters and pain in adult scoliosis. Lateral listhesis, obliquity of L3 and 4 end plates, lumbar lordosis, thoracal lumbar kyphosis are very relevant. It seems that the amount of Cobb angle, it's not that important. And patients, it demonstrated that patients with lumbar curve, especially lower apex, showed greater disability and poor health status than patients with thoracic curve. And also patients with high grade of sagittal modifiers are more likely to have spinal surgery. So restoration of sagittal imbalance is probably more critical than correction of a scoliosis itself, and should be taken into account when selecting patients for the appropriate surgical option. So this is the classification, basically, in terms of type of coronal curves, plus the sagittal modifiers, and this relates to quality of life scores. It suggests only a treatment. You can split patients in operation and non-operation, but does not suggest the specific operative method. You have to be aware that age, symptoms, comorbidity, body mass index, flexibility are not taken into account in this classification. So surgical strategies should be individualized. A very nice paper from Korea showed on the opposite that radiological parameters showed a very weak correlation with clinical parameters. And the only relevant sagittal balance modifier was the difference between PI minus LL. And those patients with high grade, they have high rates of surgery. So clinical factors should be considered instead of radiological parameters for proper management of degenerative lumbar scoliosis, according to these authors. So it's very important that you look not only to X-rays, but to a proper clinical evaluation of the patient. And the exact nature of axial pain provides very important information regarding management. Axial back pain, it's a primary complaint. It's present in 90% of patients. Identification of the trigger can be challenging. You can have from paraspinal muscle fatigue, and it responds to rest. It can come from coexistent lumbar kyphosis, flat back syndrome, and in that case, you need sagittal imbalance correction. It can come from exacerbated if you lean forward, related spinal stenosis, and this leads you to decompression, or from spinal instability, and this needs fixation. Also, common is unilateral leg pain from radiculopathy. From the convex side is due to dynamic traction or stretching of the nerve root without compression on imaging. And this, you need to address this by deformity correction. Or from the concave side, which is more common from foraminal stenosis. And this needs decompression and fixation. Bilateral leg pain, it's possible. It can be a true bilateral radiculopathy or just a form of neurogenic claudication from central spinal stenosis, and this leads you to decompression. Any acute neurological deterioration, probably it can be an osteoporotic fracture or disc herniation, and you need urgent re-imaging. You should not look at only to the spine, but comorbidities. They will influence on complications and the final results. Significant tobacco history and psychiatric history are the most important. You have to understand patient expectations framed on their social and environment context. Look at osteoporosis, because this will weaken your fixation strength, causing loss of cohesion and pseudoarthrosis. And those patients have to think about anterior column support and cemented pedicle screws. And look at also at the stiffness of the curve. Less flexible curves are more difficult to achieve optimal result. And you should do flexion extension and lateral band X-rays to assess if the curve corrects more than 50%. This is a disease that progresses. It's an average of 3 degrees per year over a 5 years period in 73% of patients in one study, with worsening of axial back pain and leg pain and weakness. Because this is a progressive nature disease, means that conservative treatment should be regarded as first line initially. However, we know that this will progress, and the challenge is when and how to operate. For example, this patient over 10 years, it remained amazingly more or less oligosymptomatic. And for example, if you compare these two patients, progression of scoliosis, in this case, no progression at all. And it was the disc collapse and the surrounding end plate osteophytes that protected curve progression. So these are kind of elements that you need to pay attention. What are the predictors of progression? In a cohort study with 200 patients older than 50 years old, cup angle higher than 30, lateral listhesis higher than 6 millimeters, L5 above intercrestal line, asymmetric disc above and below the apical vertebra, and curves with increased apical rotation component. These might be indicators for sooner than later surgery. What about conservative treatment? A multi-center randomized North American clinical trial with a short follow-up, only 2 years, showed that the operative group demonstrated significant advantage in 2 years outcome. So I think initially all patients should be treated conservatively, as rapid deterioration is unlikely, and majority of patients can remain stable. Surgery is an elective decision for failure to improve after conservative treatment. This can include different modalities, swimming, exercise, yoga, manipulation. All these are ineffective. Braces seems to be not effective. They are poorly tolerated in elder people. They are ineffective when you have transverse instability that dictates most of the curve progression, and there will originate some muscle deconditioning when used chronic bracing. Of course, you can do for short-term control facet joint, epidural, and nerve root blocks or trigger point injections. In poor surgical candidates with comorbidities, it's important conservative treatment, but be aware that the benefit is limited to the side effects. Remember the four elements I told you of the pathogenesis, and when you want to do surgery, you have to achieve goals, and you have to decompress symptomatic, static, and dynamic neural element compression, restore sagittal balance, probably more important than coronal balance, improve quality of life of patients with surgery, which can be achieved in a really good number of patients, avoidance complication, and this is relevant in the context of procedures that have high complication rate, which can be around 40%, and in patients with advanced life, which means significant medical comorbidities. So there is no universal guideline. To achieve specific surgical treatment goals, you need to individualize treatment. It's, for example, as you see here, different things were obtained with XLEAF for posterior release and fixation with one of my patients. So the indication for surgery, the primary indication is radiating leg pain and neurogenic claudication from foraminal stenosis or nerve root traction, progressive neurological deficit, disabling axial low back pain not responsive to conservative treatment, although only for relieving low leg pain, the indication of surgery only in low back pain may be controversial. If you have a documented curve progression causing pain and fatigue, and cosmesis if the patient requires, and if the patient is physiologically sound for the surgery. I'm going very briefly on kind of surgery that you can do. Decompression alone only suitable for symptomatic central stenosis and lateral recessed stenosis. No major instability, rigid segment, mild deformity, and maintain sagittal balance. Don't do more than 1 or 2 levels, and whenever you can, employ minimal invasive techniques to preserve paraspinal muscle dissection and limit curve progression. Be aware of the iatrogenic destabilization caused by decompression, especially in less disc space collapse and scarce osteophyte formation. So in those patients, you need to do routine post-op surveillance at regular intervals. And decompression alone should be avoided in the apex or proximal or distal ends of the curve. You have to have fusion and with posterior bone work, and this will address axial back pain, tackles the radiculopathy by traction on the convex side, offers some degree of triplanar curve correction, and you should do this immediately when you identify factors of curve progression. It's limited to mild to moderate curves and suitable for rigid curves where you have to do some anterior release. You can do short constructs or longer constructs. Whenever you do a limited decompression, you can do a short construct, but you are prone to have adjacent segment disease in the unfused segment, which is a common complication if the fusion, especially if the fusion stops within the deformity. So most of the times you are to do longer constructs. Fusion should continue above and below the apex. When you have severe lateral subluxation, spondylolisthesis, brachialisthesis, and the upper instrumented vertebra, it's always better to be horizontal than tilted. You need some interbody support, to correct the coronal deformity, and it's the best way to correct sagittal balance, obtain solid fusion, and prevent loss of correction. Different methods, I'm not going through all of them, with different merits and capacities, and this interbody support is relevant in patients with higher pelvic incidence or large pelvic tilt, where you need to correct more the low doses. Aggressive deformity correction, you will hear more in next presentations. Of course, when you have large coronal curves, serious sagittal imbalance, and severe subluxation of the apical vertebra, asymmetrical osteotomies can restore at the same time sagittal balance and coronal imbalance. The choice of the osteotomy depends on the degree of correction required and relative flexibility of the curve. We have different types of osteotomies. The Ponte, you can correct 3 to 5 degrees per level. Flexibility is required. SPO, you need mobility of the disc, 5 to 10 degrees per level, and PSO for more rigid sagittal imbalance, and you can correct up to 30 degrees per procedure. So, in conclusion, failure of conservative treatment to deal with leg and low back pain, progressive neurological deficits, deformity progression, and patient expectations are good indications for surgery. Selection of surgical techniques implies a careful evaluation of major symptoms and underlying medical disease to minimize postoperative complications and to solve and release these symptoms. The optimal strategy should be individualized and is a trade-off between correction of surgery correction, incorporating long segment fusions, which provide best chance of outcome, versus minimal surgical intervention just to solve patient problems. Top angle is not as much as a dominant role player, and other factors as lateral asthesis, spondylolisthesis, stenosis, sagittal imbalance will play equal, if not more important role. And aiming that direction is critical in order to improve clinical outcomes. Thank you.
Thank you, Oscar. Thank you very much.